Fighting Blindness Canada's Viewpoint is an education series that brings you the latest in vision research presented by health experts from across Canada. The session you're about to watch is a recording. To learn more about the research we fund and upcoming events, please visit our website at fightingblindness.ca. This Viewpoint is proudly presented by Bayer and supported by Abbvie, Apellis, Astellas, Biogen, Janssen, Novartis, and Roche. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below.
Really fortunate to be joined by two local docs. We have Dr. Bryon McKay and Dr. Rosana Martens. I'll tell you a little bit about them and then we'll get into the questions. So Dr. Bryon McKay is part of the West Coast Retina Consultants team. He has done a PhD in molecular physiology at McMaster University and also medical school in Melbourne, Australia. Seriously, we have to talk about that. That's pretty cool. He's also completed his ophthalmology residency in my hometown, the University of Toronto, and his fellowship here at UBC. His clinical expertise and research interests include retinal detachment surgery, diabetic retinopathy, and age-related macular degeneration. There are still lots of seats up here at the front if you want to come up. And then, of course, Dr. Rosana Martens is also here, and she's a retina surgeon who grew up here in Chilliwack, BC. She's attended UBC for medical school and completed her residency here for ophthalmology and visual sciences. She then moved to Edmonton for a 2-year surgical fellowship and is now locuming in BC as a retina surgeon. So thank you both so much for joining us today. So I thought we'll start off with like one of my very basic questions and then we can get into your more specifics. So I would love to talk about, there's two different main types of AMD, wet and dry. So maybe one of you could tackle what is wet AMD and the other could tackle what is dry AMD. So.
Is it working? Okay, good. I will tackle dry AMD. So dry AMD is usually the underlying process of all macular degeneration. So it starts slowly with accumulation of waste products underneath the retina, in between the retina and the cells underlying the retina, which are very critical at nourishing the actual photoreceptors, and you get a buildup and accumulation of material from breakdown products, and it doesn't clear properly, and it can be just like very mildly inflammatory, and it's builds up very slowly over time, causing a slow degeneration of both the underlying cells, which are the retina pigment epithelial cells, or the RPE cells, and then the photoreceptors on top of those as well. And as you slowly get loss or dysfunction of those cells from these waste products accumulating, that's the early stages of macular degeneration. And we see that on some of our scans. We might show you as these little lumpy, bumpy lines that should be straight, is usually what I say. And those are the drusen, these accumulating byproducts. And over time, that can cause further degeneration, which is kind of later stages where you get this geographic atrophy or large patches of photoreceptor loss that we've heard about before. And that's where you get worse visual impairment. And that is typically centered in the center part of your vision, so it's quite critical. You get some dysfunction and loss of vision, but then if it progresses as far as geographic atrophy, that's where you have a profound loss in central vision. And many patients that experience that or have that kind of advanced form of macular degeneration have that really large central scotoma or vision loss that's quite difficult for reading. It makes our job a little difficult because at the moment, at least in Canada, there's no approved treatment for that aside from using some of the nutrients that we'll talk about, I'm sure.
Okay, and then so within macular degeneration, about 10% of people develop the second type, which we call wet macular. And what this is, it's a new blood vessel that grows. We call it a choroidal neovascular membrane, but it's a little blood vessel that grows and leaks into and under the retina and leaks fluid. And when this develops, it's more sudden, so patients typically notice it and typically come in more quickly. And we have treatment for this, so the sooner we catch this, the better. And that's partly why when we see patients in clinic with dry, we tell you to check the eyes, every week and look at a little graph on the fridge and to monitor for this. So when this happens, we start patients on treatment. We have 3 injections available in Canada, Avastin, Eylea, and Vabysmo. And this is where there's a lot of research in gene therapy and things to provide patients with less of a treatment burden, because these treatments are often start out every month and they go longer. So it's a lot of visits. It's a lot of impact on your lives to come in for these treatments. So ideally we would have something with longer longevity to, I guess, improve your life.
Thank you. That was a really good introduction. So do people have specific questions they'd like to start with? I have a list too, but I'd like to give the opportunity to bring your questions out. Helga, I know you had some questions. Do you want to get it started? Okay, let me bring you the mic.
My name is Helga. I've had macular degeneration. I've been in treatment for 11 years. The reason I'm here today, I want to find out, I always have been told the damage that has been done by AMD cannot be reversed. Also, I want to know, is that still true? How does gene and what is the other one? I forgot it right now. Yeah, stem cell. Is there any hope with those, or is there anything else that I don't know about? And also, I have a problem with floaters. So I have a question, are they here forever, or will they get worse? So this is quite loaded. Yeah, so who would like it?
Okay, thank you for your question. So there is hope. So sort of linking back to the lecture by Dr. Yang, there's a few ways this could be approached. So they have the optogenetics, where if they can use gene therapy to change some of the cells that are already in your eye, like the nerve cells, then you could have some increased function, even though you have some permanent damage to those photoreceptor cells.
I lost my central vision.
Lost your central, yeah.
The right eye is not developing the same thing, but slowly the function is going down.
Right, okay. So a couple more things to mention then. And you're not getting injections, you have dry macular, I assume. So the other sort of area of research would be stem cells, which it could treat, any disease which has bad atrophy, could be used very generically to give you more vision back. And there's trials going on for that as well. With dry macular degeneration, there are also some drug therapies which are in the works and actually available in the US already. You may have heard the medication Syfovre. And this would be more focusing on your better seeing eye, on your good eye. So these treatments would slow down the progression of the atrophy in your better eye. And that is more likely to be here sooner than, the gene therapies that we're talking about, because they're already using this medication in the US, which we can talk about more if people have more questions about that. Syfovre, Syofvre. Did I spell that correct? I'm like, I didn't do so well in spelling in school. Yeah. Yeah, so we can chat more about that, but there is hope. Those are all things that you could be a candidate for.
So you're saying there are trials going for treatment?
Yes, yeah. In every area that we've mentioned, there's trials going on.
And how about
Yeah.
the floaters?
Okay, floater time.
Okay, yeah, I love floaters. So, well, everybody's going to get some floaters at some point in their life, because the vitreous gel, which fills up the eye, it's called the vitreous. It's the substance that fills the majority of the inside of the eye, breaks down over time, and sometimes you get long strands of breakdown of these little proteins, and you can see them. But with injections, we're introducing drug into the eye. So if you've had injections, some people will have more floaters after injections. Sometimes it's air, but oftentimes, especially in BC, if the physician's using a lot of Avastin, depending on the type of syringe they have to use, sometimes there's tiny silicone bubbles that are lubricants that are in the eye, and some people are bothered by those because they can see them. They glisten a little bit as floaters. But if there's also just the forced breakdown from repeated injections in the eye of those products, so you get more floaters. And so they're very visually bothersome. Even if you don't get injections, you can have them. Over time, yeah.
Look at scenery. I'm looking through dirty glass.
Yeah, and
I can see them, and sometimes they unite together, especially when I do something, when my blood pressure goes up, with round circles in different colors. It's really, and then it goes in the center of this eye, and that's my good eye.
and then it blocks. Yeah, and that's the tough thing with floaters. The definitive answer is there's only really one way to get rid of large floaters, and that's with a surgery. But surgery has risks, and we often don't like to do that surgery. They've trialed lasers before. Some people offer that still in Canada. Very few retina surgeons actually do that anymore, but there was some trials that were even done in BC looking at that. But what oftentimes happened is the large floaters would kind of go away for a bit, but then they'd kind of come back as more breakdown happened. So people were less interested in continuing to do that because they didn't find it was very helpful in the long run. And then if you look online, there's a lot of discussion about floaters because they're very bothersome to many people. So some people use nutritional elements, pineapple extracts and things that are, anecdotally may help, but there's no real medical trials, or at least or scientific trials or evidence to support that. But some people try that, and I don't usually dissuade them as long as they've cleared it with their physician.
I've been treated with Lucentis for quite a long time. I can't remember, about since 2006 maybe. And now I'm getting Eylea. And my vision has quite stabilized, except slowly but surely. There is now a decline. I can read less than I could a few years ago. And I wonder, is this something that will continue? Is this something that can be stopped, or, just, I don't know what to say really other than that. It bothers me.
That's a great question. We get that a lot, actually, because in the trials, there is a continual kind of slow decrease in vision over time. And I think of it more of the way the disease is. So we always tell people, oh, now you have wet macular degeneration, but you actually still have dry macular degeneration. You just have also neovascular membranes or wet macular degeneration on top of that. So you still have this slow kind of brush fire, I call it, underneath, just this insidious decrease in function. If you don't have geographic atrophy, it's really slow, and just unfortunately you ended up having a neovascular membrane, which at least was treated, because you must have been one of the, it was fairly new probably when you started. You must have been very early in the treatment. So that's great, because prior to that, the natural history would be that you would get a big scar from the bleeding, and you'd lose all of your central vision quite rapidly. So thankfully we do have injections, but for you, just duration of disease, you'll have some slow. So that's where we're getting to now with the new treatments that may help slow geographic atrophy at least, and hopefully soon also just the whole process in general, or gene therapy to kind of halt it maybe. That's where people are looking at now, because a lot of patients have been treated for a long time for wet, but the dry is still continuing, and that's one thing. So at the moment, I always tell people, if you're still a candidate for AREDS 2 based on some of the criteria, that's probably better to keep going with that, as long as you don't have very large patches of geographic atrophy that we know it's likely not going to cause much benefit to continue using an AREDS 2 vitamin formula, because it may still decrease the trajectory of the loss of tissue. The studies show usually about a 25% reduction in the risk of progression, but that I think still has some play there, because really that's at the moment that's all we can do. But I think a lot of new treatments are kind of directed into that question in general, is like, okay, we can slow down the bleeding or stop the bleeding, but what do we do with the rest of it? Yeah. So it's a very good question, and this, you know.
But the gene therapy or anything is still not happening for us, right?
As far as there's no approved gene therapy at the moment, but there's clinical trials in multiple phases happening, which is great. And that's also true for what we were discussing before about actual stem cell therapies, whether it's induced stem cells, so they're your own tissue, or it's tissue that you already have, like stem cells from your own body, reprogramming them to become retinal cells. Those are very aggressively being worked on right now by a lot of different labs, including labs in Toronto that are doing really good work on that. So hopefully sooner than later. Yeah.
Can you talk a little bit about sort of talking about gene therapy? What sort of gene therapy options are there? I think I've heard that there is things where they can start producing anti-VEGF within the eye. Is that being looked at?
Yeah, so I guess maybe one step back is with gene therapy, they're looking at ways of delivering it to the eye. So there's sort of three ways that is being studied. One is an injection into the eye, like you get for everything else for the Avastin. The second is a special technique with a sort of short little tiny needle where it's still on the outside of the eye, but it goes into, they call it the suprachoroidal space. So it's the space between the sclera, which is the white of your eye, and the blood vessel layer. And that is thought to have less exposure to the immune system. It kind of sneaks its way into the retina without your immune system attacking it. And then the third, which Dr. Yang showed the video of, is called subretinal injection. So it's a surgery. You go inside the eye and you actually inject it under the retina. So those are sort of the three things being studied. There is, like in BC, in Surrey, they're in phase 3, have joined RGX trial, which is a subretinal injection for gene therapy. And what this injection would do is it would help the body produce VEGF, anti-VEGF, which would mean you don't have to go for all these injections. I'm not sure if that answers your question.
Yep, no, that was
Okay.
exactly it. Thank you.
Yeah.
And I think there was another question.
Actually, you kind of answered my question because I was wondering about the dry macular treatment that's now in the U.S. and assuming it will be approved here, you would use it in conjunction with wet if someone also has wet. You could use them together.
Definitely, yeah. It could be used together. Either you have wet macular already, and then we see that you have dry component with some atrophy developing, or you come in and you have dry macular degeneration and you're a candidate. So the injections, one of the sort of side effects is it slightly increases your risk of developing wet macular. So so some patients who they go under the treatment of this new drug, Syfovre, and there's some others. I'm just mentioning the one name that if you did develop wet, then yes, then you would have both injections.
So I was diagnosed with dry in both eyes,
Yeah.
and now I've developed wet in
Yes.
both eyes.
Yeah.
So having said what your answer, then
Yeah.
is there a risk that the oral drug would actually make the wet worse?
That's
or
actually a good
escalate it?
question. I don't know if we know the answer to that yet. I'm not sure. I don't
Okay.
think we know the answer to that yet. Yeah. I think that's something that will have to be seen. Yeah.
Okay.
Other questions?
I've heard it's an inflammatory disease, is it? And would anti-inflammatories help?
Yeah, so there's a component that some of the new medications are looking at is an inflammatory pathway called the complement. It's part of your immune system, and it's about slowing that down because it does incite an immune response in the eye. There are immune cells that come into the retina that are not normally there as part of macular degeneration. But taking like an oral anti-inflammatory hasn't really been shown to halt the disease progression. So that's not, it's not unfortunately, that doesn't really help do that. But the targeting pathway members of the inflammatory cascade seems to help reduce the disease burden or the progression of the disease. It doesn't halt it completely, but it definitely slows the progression, which is important. Yeah. So it's more of a targeted thing. And most of our anti-inflammatories you take orally are kind of like a large, they kind of work at the very top of the pathway, but it doesn't block certain parts. So that's why they don't really work. They're not as targeted, so to speak, yeah.
Thank you for what you've told us so far. It's interesting to look up other drugs. But from my understanding, I guess Syfovre, it's not authorized yet in Canada. It does potentially slow geographic atrophy by 19 to 22%, but it has its risks. So I guess I'm interested to hear what the two of you might have as recommendations for, let's say, so my mom has the geographic atrophy at this point. She'd been through a lot of the injections. And also I'm going to speak for mom and say, whoever wants to chat with her and me, feel free. So I'm wondering what other suggestions you might have for, let's say, non-medical things she can do. So she's taking an AREDS formula pill supplement that I think we got from the eye clinic that she goes to now. She does eat pretty well. But any other ideas, suggestions that you guys can think of that you've seen, again, might make little improvements?
If you look at some of the trials, or you're looking at some of these websites, there are various things people are trying or tried. And one of the ones out of the AREDS group of studies was the Mediterranean diet. And that seemed to, it's hard to study diet because it's a recall thing, but people that tended to eat more of a Mediterranean diet, so rich in fishes and vegetables and things like that, and less ultra-processed foods like the Western diet, tended to have less disease progression or less advanced disease, then they still had macular degeneration, which seemed in a large population to have less advanced disease or less progression compared to a Western style kind of ultra-processed diet. Things like exercise, staying active. The main modifiable risk factor is smoking, so quitting smoking if you smoke is probably the main thing. But most of the other risk factors are not modifiable: genes, age, your background, and things like that. But in terms of other things, I read something yesterday, actually. It was like saffron, and they were looking at saffron, and it seemed to, and so there's all these nutritional things that may or may not, but it's probably goes down the road of either being heart healthy or vascular healthy. Those type of things are probably better for the retina, because the retina is a hypervascular tissue underneath the choroid. That area of blood vessels we were talking about is one of the busiest parts of the body in terms of blood flow. It has the highest blood flow per millimeter of any part of the body. So anything that's healthy for the blood flow is typically healthy for the retina. And so you can look at it that way. For lifestyle issues that may help, but it's very hard to study these things because a lot of times we're looking back on people that already have a disease, and it's hard to do a prospective trial. The AREDS group has really done the most just because they've been following so many people for so many years. And Emily Chu is one of the founders of that, and she's actually from Vancouver, so it's kind of cool, little local shout out. But in terms of all of that, that's my, I don't really have any specific advice to patients typically, except for trying to stay active and trying to eat healthy if you can. Yeah, and quitting smoking is the number one, but most people are not smoking anymore.
It's interesting that you say that, and they're good suggestions, because I remember many years ago when Mom first was getting her injections for macular degeneration for the wet, and the doctor said, well, you can maybe take supplements. Oh, sorry. But it's interesting to hear you say, when you make a suggestion, I think it's worth us checking out, because you never know, in a few years, the science may back up that suggestion, because way back in Mom's initial diagnosis, she was told, well, supplements, they won't really help. We think maybe try it, but we don't have the science yet. sure enough, now they're realizing like it makes a difference. So I really appreciate, your suggestions. So thank you.
Just on that note, when I was at the Stanley Park conference a few years ago, there was a researcher doing a connection between AMD and gut health. And I thought that was really interesting because there's so much information now about gut health related to all sorts of other things going on in the body.
Yeah. I'm just going to say quick that Dr. Safaya, I can never say his name correctly, is still working in that area, and he's actually had some success looking at that information. We have more about that on our website, and we've had videos of his talks about his work too, if people are interested in that.
Can you talk a little bit about the inherited factor of AMD? Is there any sort of research that can confirm or deny that's, it is a disease that can be inherited?
So I don't know if you know more than me. I would say that it's multifactorial. So they have identified a few genes that can contribute. So it's like ARMS2, CHM, there's a few genes which confer a higher risk. But it's not like the other inherited diseases that we talked about earlier, where, it's dominant or recessive, and if your parent has it, you have a high probability. So, because the question I often get from patients is, their daughter or son will be sitting in the chair in the room, say, do I need to get checked? It's hard to know, but it's a good idea too, but it's not a sure thing. So yeah, I don't have much more to add on that as far as family risk. Yeah. Other
One thing to add on that. So in that same context, people will sometimes have like a 23andMe or one of the online things where you submit and you get like a gene panel back, and they'll say, oh, I have like ARMS2 or CHF gene, and then they freak out a little bit. But even with both of those genes, it's a high risk, but it's not 100%. So you can carry both copies of those specific two genes, and you may still not get it. Or you could have no genes that we know of and still have it. So that's what the hard part is about that, because the acquired kind of nature of this. And we're not really sure about the epigenetics around that too. People that have genes and don't have genes, and whether or not those genes are active and things like that. There's a lot of complexity to just genes in general, but in terms of how they're expressed and to what degree in the retina is very difficult to understand. So that's why I tell people to interpret those tests with caution and try to do the healthy lifestyle choices that if they're young, that they can still do. Yeah.
Yeah, we get that question a lot at our health information line. People ask about tests like macular risk and if they're worth getting. And from my understanding, and please correct me if I'm wrong, I think the general recommendation is that the genetic testing, even if you have it, just as Dr. McKay said, there's no guarantee, but also it doesn't really change your treatment outcome at this point. Right? So even if you find out you have the genes, there's nothing that's going to actually change about the way that you're treated for the disease. Is that accurate?
Correct, yeah, because now, so that we used to do that with inherited retinal diseases too. We'd just be like, well, we can't treat anything. Everything is retinitis pigmentosa, and that's it. But now, as we were hearing earlier today, there's a lot of genes. So now when I see patients, I'll send them for a test, and then we'll put them in the registry, because we're hoping that there's going to be more treatments. But for now, the AMD, kind of the bottom line treatments are still going to be trying to focus on the retina and restoring healthy retina tissue. So even the genes that we may use for treatment, at least at this stage, would probably be things like either suppressing endogenous or self-made VEGF that's leaking out from the tissue, or supplying, having the cells that, like we just said, that supply anti-VEGF from inside the eye, things like that. So those are a little different. That's why interpreting genetic tests with caution is very difficult. So genetic counselors are very specialized people that really know this stuff well, and most people just reading a test have a hard time interpreting it. So that's why we say with caution for sure.
Absolutely. And I get questions about 23andMe all the time too. And that's not really a comprehensive genetic test. Like if you're going to get a genetic test, you need to go through your eye doctor. You need to get it through a genetic counselor, because those results just sent back to you mean nothing unless there's someone who's trained to interpret it and tell you what that really means. Are there other questions in the room? Oh, everyone's hands are going up now. Oh, sorry, so sorry. Heather, I'm going to come back to you. There's one more in the back.
It's more along the line, this is being filmed, so I'm assuming that like new patients as well as patients that have been treated for a long time are all potentially watching this. So I think I'm most curious about what are some of the big questions patients are asking you when they're initially diagnosed, and what information do you think that might get lost in that initial diagnosis that would be a great reminder for those patients like 3, 6, maybe 1 year down the line, so that they can revisit the information just to help them help themselves.
So with what Dr. Martin said was, catching something early, especially if you've been diagnosed with dry macular degeneration. I don't suggest people dwell on the Amsler grid like all the time and obsess over it, but I do suggest that especially in early course of the disease, maybe once a month, checking monocular vision, so one eye, then the other, and looking at it, keeping mind on straight lines. When they do that, is it a little wavy? And if it suddenly changes or changes within a short period of time, that's when they should call and be seen quite quickly, because catching something early, a very tiny bleed is great. A large macular hemorrhage is quite devastating in terms of final visual outcomes. So that's my first tip, is just to use the grid, don't obsess over it, but definitely use it a bit, and not to forget to check one eye, because oftentimes we have a dominant eye. People don't think about this, but it's very easy to have a dominant eye that's fine, and the other eye actually have pathology in it that we don't really recognize until you block the other eye. And as even through my training, we see people that one eye had something severely wrong with it, not from AMD, but for something else that they just found out suddenly, but actually had probably been going for years. And so we have a dominant eye, so that's why checking one eye at a time is critical for this disease to catch it early. Yeah, and that's my first piece of advice.
I would say the other question I get a lot is how often or how long do I have to get these injections for? So, because I think sometimes on the first visit, a patient thinks that it's a one treatment and done, which hopefully one day with gene therapy it will be, but it's not yet. So I'm always like, take some time to explain that it's right now it's sort of a treatment, not a cure. That's what I say to people. And when I come back, I feel like I reiterate that these treatments are ongoing, and give some explanation to the patient about why we have a certain interval. Like if we can go longer between treatments, I sort of explain why. Because the vision may be a little bit better, but not perfect. So just explaining that, okay, things look good on your scan. We can spread out your treatments over time, and involving their family in that as well, because it's a big burden on friends and family members, whoever comes in with them. So patients end up spending a lot of time in our clinic. But on the exciting end, with new treatments coming available, hopefully it can be less of a burden in the future.
Yes, it's about progression. So injections have been around now for 20, 30 years. How much has it slowed the progression?
A good question. So without an injection, and all we would have is laser, the progression is like 100%. So you will have people lose central vision usually within 24 months or so. Around. It could be quite quick. So slowing the progression or halting the progression of wet. In some patients, we actually halt it, and we say dry up. When we say like dry or wet, or in the clinic, you'll probably, we point at the screen, there's all these lines, and it's dry today, boom, injection, go at night. So we don't explain it very well, but in terms of what we obsess over is it progressing? Basically, is the fluid worse in the interval or better in the interval? And then we look at the vision, but the vision sometimes it depends on how people come in and when they come in at. So in terms of progression, there's disease progression and vision progression. When we're treating wet macular degeneration, we're looking more at the outcome interval to interval. We spend a little bit less time looking at how far you've come, unless we check the vision stable. So I have many patients now that have been treated through different physicians, but we've kind of accumulated that have been treated for like 15 years, and they're still maintaining less than 20 or better than 20/50 vision. And so they're able to drive still, which is great. And then there's obviously some that progress much faster. So the disease will still progress despite the injections, but again, it's if we halt the wet form with the injections, the dry form will still continue, and that can dip the vision interval by interval or just very slowly. Unfortunately, when people start developing geographic atrophy is when vision really starts to dip, and we sometimes don't even notice much on the scan, maybe like 1/4 of a millimeter, tiny, tiny change, but people like, I can't see anymore in the middle. I lost like the very center of my vision. And that's still devastating to try to explain in a short visit, but it's dry, but you're losing vision. And so in terms of progression of the wet, we've done it's pretty amazing actually, the difference between pre-2005 and post-2005 in terms of where people would go. If you're anyone in this room had wet macular degeneration in the middle of the 90s, probably have really bad scars. So when we still have patients that have been treated, they're 30, 40 years in their disease process, we still have a few in clinic, and they both have bilateral, we call them disciform scars, which just means that the wet bled, and it's just a huge mass of scar tissue, and they cannot see. So it's quite amazing how we can, since then, we've been able to stop progressive vision loss. Unfortunately, still have a little bit of dry going though. So I hope that helped. Did that answer your question? I feel like I was rambling, so sorry.
That was great. We have one more question. Here you are.
Thank you. I was also wondering, because now I keep hearing that some of these injections are maybe more powerful and they are given at a lesser or a greater interval rather, so maybe every 4 months rather than every 2 months. Does that mean though that there's a greater risk of some of the side effects by having those?
Yeah, so there's a new medication, Vabysmo, the 16-week that you're kind of referring to, allows you to, it doesn't necessarily mean that patients can come every 16 weeks, but it would basically allow you usually to get a few more weeks out of your treatment to lengthen the interval. So, for example, a patient who I may be treating every 4 weeks, maybe we can get you out to 8, which is great. The risk of side effect is not higher. So I would say the risk of side effect is probably lower because you're having less injections. So side effects being like infection, cataract floaters, all those things, if you have 50% as many injections in a year, you're reducing your risk. Sometimes with new medications, we see unexpected things like inflammation in the eye, which they've had with the Syfovre that we talked about before for the dry type. So sometimes that when things are new on the market, we're still discovering new things. So that sometimes a new drug can have some unforeseen side effects, but in general, it's better. Yeah.
Because of the injections. Would something like that increase the risk of having the eye pressure going up?
Yeah, so having a medication that you can go longer with. Again, I think having less injections would be a lower risk of that. Yeah, because you're having to come in less often. So yeah, I think that would be a lower risk for.
Okay, we have one last question. One. I can never say no.
I have a very good ophthalmologist, and my dry seems to be progressing in that I almost lost my driver's license last winter, but I managed to squeak through. So at what point would it be good or helpful for me to be referred to a retinologist? Like, what is the criteria? I'm sure she knows. She must know what the criteria is, but I'm just curious. At what point do you get referred?
It's a good question. So with dry macular degeneration, a lot of times people will periodically refer to a retina specialist just to make sure, especially if there's some larger, some of these drusen become quite large and they're kind of, some people are like, I'm not sure. So they'll usually send when they're not entirely confident that you don't have dry or wet or that you're not at a high risk for wet. Many will just refer if it becomes wet, because they're maybe a comprehensive ophthalmologist and they're very comfortable with the OCT scans and reading those, and so they'll just manage a patient until it's time. Or they're a very, well-read optometrist who's been following with scans, and then they're very comfortable with knowing when it's changed to the wet form, and sometimes they'll periodically do. So in terms of when to be referred, at the moment, probably if they notice fluid or something that seems like there's been a change, either your vision, you have more distortion in your vision, that's one main criteria I find people will refer to us. The other is if it's wet. Moving forward, as some of the newer drugs that may treat dry macular degeneration, or at least the geographic atrophy form of that, people will probably be getting referred a little bit more frequently in terms of, is my patient a candidate for that medication? And that's where we're still working that out at the moment with the company and with the data, yeah.
Okay, I think we're going to have to leave it there. Our time is out. But thank you so much to both of you for being here and for sharing your expertise with us today.